afternoon. That's good that we had coffee break first, because you are going to listen now 20 minutes about pathology. So in this, I will talk about I will first introduce you the team of pathology for the Mutographs project, and then some insights about organs that we are working on them, cancer types that we are working on them, and then a little bit of discussion about the role of pathology in this kind of studies as I see that. So first, meet the team of pathology. Pathology workflow of the Mutographs is centralized at IARC. I am leading that. I am a double board certified pathologist of clinical and surgical pathology with a strong background in the field of esophagogastrointestinal pathology. And also because of my background work at IARC, some experience in the kidney, head and neck, and lung cancers. And for these specific projects, I invited the colleagues that I did know their efficiency and their commitment, and their expertise in the field. So I have six pathologists, external ones that work in the field of gastrointestinal and hepatopancreatobiliary. I have 4 from Iran, 1 from France, and 1 from Canada. And with myself, so we are 7 to do the 4,000 of the cancers that are in the category of gastrointestinal in the Mutographs. And for the kidney cancer, uropathologist, I have Sophie from France, plus myself, that we take care of kidney cancer. And of course, we have Christine here at IARC, are very efficient and very highly experienced research assistant in the pathology lab that provides all the technical needs that we have to have to be able to do our work. So Mutographs has some criteria about the inclusion of the patients. First of all the cases should be chemoradion naive, and they should have frozen tissue plus blood and questionnaire data. And we have to evaluate microscopically all the frozen tissue to be sure that about the morphological type that is the interest of the project, and they should have at least 50% viable tumor cells. So this led up to think that, first of all, it is about 7 years that we are doing digital pathology. We have moved from light microscopy to digital image-based pathology at IARC, and it is really the need of these kind of projects that we need to have multiple expert peoples. And we provided very precise SOPs after multiple pilot discussions between each other, we pathologists, to understand what we really want to do and how we really want to do that. And we have a very precise method that explains about how we look at the tissue and what we provide. In fact, it is about the percentage of the number of viable tumor cells, of inflammatory cells, any other non-tumor element, and necrosis. And we continue to have multiple web-based discussions between us in case of difficult cases that we don't have agreement at the first, and we need to discuss to reach to a final agreement. So if you are interested to know the details about the pathology process, there is a poster in the poster session number 20. You could have a look on that to know the details. So let's have a go through together. That is what can I say as insight about the pathology work. First of all, as I explained you, we do digital pathology. It is image-based, and we at IARC, I am very used to that, but it is not the routine practice of pathology. So convincing pathologists to change the habit from light microscopy to image-based is one thing that affects this kind of projects. But the most important thing that we have, and it's a real issue, is about working with frozen tissue. Pathologists don't like microscopic analysis, including me, myself, on frozen tissue. It is about 10 years that I'm doing only frozen, and I really miss formalin fixed tissues, because it is what we really need. Frozen tissue is not made for detailed microscopy. When you freeze a tissue, because of the water content that exists in any kind of tissue, it makes some artifacts in the tissue that destroys the detailed structure that we need to provide our precise diagnosis. So we miss that. And this depends on the method, on the duration of keeping the tissue in the freezing status, in kind of tissue, and also the time that the tissue has been out of body without blood supply before being frozen, means exposed to hypoxia. So to give you an input, it has when you look at this tissue, it is really just a very structureless tissue. And when we look at a more higher magnification, I can see some elements that are definitely tumor elements, but there is no way for us, nobody can say what kind of tumor elements they are. So we have one of the reasons that we exclude these kind of samples, even if the center confirms that it is, for example, colorectal carcinoma, we cannot include these cases because we cannot confirm the morphology on them. But does it mean that we are not precise on when we look at the frozen tissue? It's not really true. We are kind of very precise. Well, precise in a way that we can provide our diagnosis about the tumor type. Even for you, I think, if you are not pathologists here, and this is a piece of frozen tissue, you can see that there is an absolute difference between these elements and the other elements. They don't look the same. And when we look at the higher magnification, you definitely see that there are these ugly things here, and then there are another kind of tissue here. So this is tumor, this is non-tumor. We can say about the morphology. But what we need to provide in Mutographs is that to say which one is inflammatory cell, which one is, for example, fibroblast. There is no way that I can say in some of the specimens to say precisely. I may say it is inflammatory cell if my colleague, one of my colleagues is sitting here. If he says no, I say it is fibroblast, I would say yes, you might be right, because we cannot go further than in this kind of tissues. It is the artifact of frozen tissue. It's not the case in formalin tissues. The other thing that it is one of our challenges, in fact, it's about necrosis. Necrosis is a pathologic event that happens in all of malignant tissues. We try to avoid it through our SOPs. We ask our colleagues not to avoid, because you can see necrosis, but sometimes it is really microscopic. So anyway, we have necrosis, and necrosis is in fact dead cells. So it is not counted in our estimation when we say number of viable tumor cells. But it remains in the tissue, and it is one of our main topics of discussion between our colleagues to be sure that what we really call necrosis and what kind of cells there might be in the necrosis, which is usually infiltrated by inflammatory cells. The other very difficult thing to distinguish in frozen tissue is about inflammation. And in the cancers that are studied, especially in the Mutographs, some of these cancer types are quite inflammatory background, even in normal tissue, like colon. We will have a better look on the colon. But in this specific, just some example here. Here is a piece of tissue that has colorectal carcinoma, and you see, and only one field. We have tumor, we have big collection of inflammatory cells, and we have some elements of non-tumoral colon tissue. So we have to count them properly to be sure that the percentage of tumor, and this is only one field, so we have to look at the whole section of a tissue. So separation of this, you see that I will come back to this when we look at the numbers, when we provide numbers, how much it is important to be as precise as possible to provide this information. So I provide some more examples about this was general, applies to any kind of frozen tissue, any kind of cancer tissue. But when we want to look at the specific cancer types that are examined in the Mutographs study, I start by esophageal cancer, and especially esophageal squamous cell carcinoma, which has been the most of our work during these 2 years. I intentionally provide you these slides here. These are the image of our slides to show you when we say that we want our patients to be chemoradion-naive, it limits us to use mucosal biopsies for some of, at least for esophageal squamous adeno and the big part of colorectal carcinoma patients. And biopsy, when it is the matter of biopsy, so the issue is about the size, is about the expertise of the endoscopists to get good size and reliable biopsies, and about the instrument and the equipment of centers. We have about 40 recruiting centers with different facilities, and we try to provide feedback to them to improve their activities, but in fact it's quite challenging, not only for us, but also for our technician at the lab to handle these are really, the size is real. I am not minimizing them. So when we start to, now here is magnified, when we look at the microscope, so the size, for example, the surface, it's not even the diameter. The size of this biopsy, which is considered one of our best ones, is about 4 square millimeter. But when we start to cut them to obtain the material for DNA extraction, we of course lose a lot of tissue, and each level of this sectioning, we re-evaluate them at the microscopy to be sure that the percentage of tumor, it is what we expect, but we reach to a surface of about 0.4. And it is not only difficult, again, for us to look at to be sure that we have enough tumor material in such a tiny piece, but also for our technician to handle this. The same, sometimes we start with a piece of tissue, quite big biopsy, 6 square millimeter, and we say that pathologist has confirmed that it has at least 50% tumor cells, but when we start to cut it to obtain DNA, we lose the tumor material. Not only the tissue decreases and the tumor also decreases. Tumors, each of them has one particular character. So it's never the same in each of the biopsies. So these are the cases that we exclude them because we don't confirm that in the whole process we kept the percentage of tumor. But here, because I really like to highlight the work of our technician, because we apply, again, in the poster is very well detailed explained, we apply some enrichment techniques that we want to get rid of non-tumor elements and to enrich the tumor material. Sometimes we annotate the unwanted area for our technician, and we ask her to cut this, and she is quite experienced in working with this kind of a small tissue and also frozen material. So even in such little biopsy, which is only 2.5 square millimeter, when we annotate it, she is able to cut it to get rid of non-tumor element, to keep the tumor element, and then provides us the highly enriched tumor. The second organ that we work with, and it is one of our most difficult ones, in fact, is pancreas. The interest of Mutographs is pancreatic ductal adenocarcinoma. So it is one of the most common cancer types in the pancreas, but pancreas has many others, and particularly because pancreas, it has its own glandular structure and ductal structure that the cancer of our interest starts from, but at the same time, it has a parallel presence of the biliary structure. And then this is the head of pancreas that is located anatomically in the loop of a small intestine. And here we have a very tiny area that the duct of pancreas, biliary tract, and liver, they all get together, and we call it ampulla of water. Ampulla of water itself has its own malignancies, plus malignancies that come from the origin is biliary tract, and malignancies that are from pancreas. So from recruiting centers, when they think that the clinician think that it is pancreatic cancer, then pathology excluded for this study because it might be, for example, cholangiocarcinoma or adenocarcinoma of ampulla of water, which is not our interest. So we already lose many of the cases that originally are thought to be pancreatic adenocarcinoma. But even those that pass this step and reach to us, then our pain starts, because pancreas is extremely fibrogenic tumor. It makes a very special microenvironment, which is desmoplastic and very, very low cellular. The tumor cells are just distributed as single cells all in the tissue. So here you see that it is a big piece of tissue, about 1 or 2 centimeters, but the tumor cells are only in this is magnified about 300 times. So you see that the tumor cells are only located in these green annotated areas. And another example, another big piece of pancreas, but we have the tumor cells only in these yellow line areas, really single cells. So for pancreas, almost all of the cases, we have to apply another technology, which we call it laser capture microdissection. So it is a motorized microscope that is equipped to laser beam or laser knife, and then we guide the microscope and the laser to cut these tiny elements. So we have one of our colleagues from the team, Arash, here in the session. He just joins us every few months just to do this laser capture microdissection and to teach our technicians to do it. But it is a very time-consuming and very difficult job to do. The other organ is colorectal carcinoma. Colorectal might sound very straightforward, but it is also very difficult cancer for us to handle. First is that, again, we are limited to biopsies in many of them. Second is that the carcinogenesis of colorectal carcinoma starts from adenomas or polyps. And these adenomas, they already have, all of them have low-grade dysplasia. Some of them get high-grade dysplasia. And then we have to confirm in the biopsy or a small piece if they are invasive or not. And this is sometimes very, very impossible for us because our samples are tiny and we don't have the depths that we need to confirm the invasion of the tumor. And colon, in fact, is the only organ in the whole gastrointestinal tract that all tumors that are in the mucosa, they are in fact carcinoma in situ. In any other cancers, as soon as they reach to lamina propria, they become invasive, except colon, just because of this, that the adenomas are already, when there is high-grade dysplasia in an adenoma, it doesn't mean that it is a cancer. It is why that in our review, we have added intramucosal carcinoma to the choice of our diagnosis, and this is very important for our colleagues that when we send the DNA to be sure and to know that because these intramucosal carcinomas, there might not be really invasive. And the other thing about colon is that, as I said, colon itself is very inflammatory. It has a lot of inflammatory cells in normal colon epithelium. And the same is quite immunogenic when it is malignant. So we have cellularity issue about colon. When we look at the low magnification, we think all of these glandular things, they are tumors, so we may say it is quite cellular. But when we look at the higher magnification, in the same surface area, the number of malignant nuclei is much less of the number of inflammatory cells that we are. So we may have 100 malignant nuclei, but we may have 10,000 inflammatory cells. So this is, again, something that we have to exclude many of those because of the cellularity issue. So that is, I don't talk about esophageal adeno. It is very close to about its biopsy, and it is about the background is very inflammatory, and the issue of all the junctional tumors, cardia, how we exclude this. This is really out of the scope of this session. And renal cell carcinoma also, because it's one of the most straightforward. So I thought that we keep the time, and I just have a few more slides to talk about what is really the role of pathology in this kind of studies, and what I like to mention about the multidisciplinary projects. In fact, when I was searching the web to find something to put in this part of my talk, I found this title, Molecular Pathology, the Value of an Integrative Approach. And then I found this figure, which I found it very good about what I want to say. And then I looked at the author, and I saw that it is Manuel Salto, who is our colleague here, and he will present after me. Just by chance, I found it is by him. It is his publication in Molecular Oncology in 2014. That what I believed about pathology is that pathology is really a critical discipline for the success of modern multidisciplinary projects. And I don't think it is the value of pathology is only at the quality control or at the beginning of these projects. We get a lot of advantage if we continue to keep pathology in the loop of discussions when we go through sequencing analysis and data analysis especially. The issue of purity, about the difference between we pathologists say what algorithm brings up about the purity of tumor. And even in just one example, it is known issue. TCGA data has already shown that this issue exists, and especially the most common, interestingly, is about esophageal squamous cell carcinoma. And I think the only way that we can understand, if ever we can understand what is going on, is by having a continuous discussion and getting feedbacks. If you give us feedbacks, we can also give you a good feedbacks to understand better the results of the analysis. And the last thing that I want to say is that pathologists are the best and in fact, the only ones who can make the link between morphology and molecular features. And although now it is everything about molecules, but still it passes through morphology. And examples like, for example, pancreas, I told you pancreas has a very fibrogenic stroma, but this fibrosis is really tumor fibrosis. It's different from fibrosis of a scar tissue, for example. So it might have a lot of signatures in it, or a lot of mutation features, the microenvironment of pancreas. Necrosis is something that we back to necrosis and we tell you why this necrotic tissue has a different pattern compared to another necrotic tissue. And projects like Mutographs provide a lot of opportunity for the very rare cancer types that we may never see them in our routine practice. Like this case, which is a beautiful example of pancreatic adenosquamous cell carcinoma. It is a very rare entity, but the beauty of this is that the adeno part is very clearly separated from a squamous part. And this is again something that pathologists could collect these cases and to go through how we analyze them. So that's it. I think it's the only way that by continuing having this loop, we can make the right pieces together and have a better understanding of these projects. Thank you.